Good afternoon, ladies and gentlemen. Dear friends and colleagues, welcome from all over the world. I send you my regards. I'm broadcasting live from Charité University Hospital in Berlin, and this is our virtual critical care center and the ICU follow-up center, Eric. And it's my great pleasure to welcome you to the ESICM webinar series dedicated to COVID-19. And we are talking about the management of sedation today. And it is really my pleasure to welcome our extraordinary speakers that are really leading worldwide experts in the field. And let me introduce you our wonderful speakers today. First of all, we have Dr. Margaret HERRIDGE from Toronto, Canada, who is Professor of Medicine, Critical Care and Pulmonary Medicine at the University Health Network, Senior Scientist in the Toronto General Research Institute, and the Director of Research for the Interdepartmental Division of Critical Care Medicine at the University of Toronto. Well, most of you know Dr. HERRIDGE. She has co-authored more than 160 manuscript and book chapters related to outcomes and functional outcomes after intensive care, especially in ARDS survivors, which are so important in COVID patients. And I may personally add that she really wrote a chapter of modern intensive care medicine. She is honorary member of our Society of the ESICM, and it's really my great pleasure to have her here today. And then we have Dr. Arjen SLOOTER from Utrecht in the Netherlands. Dr. SLOOTER is a consultant neurologist intensivist at the Department of Intensive Care Medicine at the UMC Utrecht in the Netherlands, so our neighbors. He is a professor of intensive care neuropsychiatry at the Utrecht University, and Dr. SLOOTER is current president of the European Delirium Association, and he chaired the SCCM Delirium section of the SCCM PEDIS guidelines. And it is really my great pleasure to listen to you too. When I prepared this webinar, I was looking at an editorial from 1998. I just came across that. And I would like to show you this editorial very quickly. It is an editorial of a very famous physician, a pulmonary and critical care physician, Thomas L. Petty. And he writes, but what I see these days are paralyzed, sedated patients, lying without motion, appearing to be dead, except from the monitors that tell me otherwise. In my search for this webinar, I actually came over this because Dr. Petty expressed his deep concern about sedation practice in ventilated patients in the late 1990s. So it's quite a long time ago, actually. And during the COVID-19 outbreak, I personally heard a lot about deep sedation and paralysis again. So, Margaret, can you hear me?
Yes, I can. Thank you.
Margaret.
Hi.
Great. Hello. Welcome.
Hi.
Margaret, do you think there is, oh, now I can see you. Hi.
Hi,
Do you
Björn.
think there is a necessity to talk about sedation in COVID times? And are you probably even concerned about sedation practice you see these days?
Yes, well, thanks, Björn. Thanks for the opportunity to be part of this. Thanks for your very kind introduction. I think like all of us, we've been attending in the ICU, and I think the practices really are concerning. And I think we are really seeing what Dr. Petty wrote here. I think about other literature by many leaders in our field, an older paper published in 1998 by Marin Colliff, who outlined that heavy sedation practices definitely keep people on mechanical ventilation for much longer. And then the important contribution, the seminal contribution from J.P. Kress and Jesse Hall in the New England Journal in 2000, showing very clearly that interruption of daily sedation, decreases the time on the vent. And then a more recent paper led by Gita Mehta, her sleep paper published in JAMA a few years ago, again showing that if we don't necessarily have to interrupt, but we need to keep people a bit on the lighter side. And again, we won't prolong mechanical ventilation. I think the mechanical ventilation practices and the prolongation of these practices really has a direct impact on outcomes. And we're seeing a return to prolonged sedation and paralysis in a way that we haven't seen in decades. I think it is concerning, and it's concerning when we think about the inherent resiliencies of our patients and how able our patients are to withstand the incremental insult of sedation, of prolonged paralytics, when they come out the other side of our care and have to face the beginning of rehab and recovery.
Yeah, thank you very much for this very important comment. I think I couldn't agree more with you that it's a very, very important topic. So I suggest that we now start with Arjen SLOOTER's presentation, who will tell us a little bit more about evidence on sedation practice, then followed by your presentation, Margaret, that will more focus on outcome. So I introduced you before, and the stage is yours, Arjen, to tell us about sedation practice.
Well, thank you very much, Björn, and thank you also for those kind words at the introduction. I very much agree with what Margaret just mentioned. Here's my presentation. First of all, I do not have any conflicts of interest or anything to disclose. When I prepared for this talk, I entered in PubMed the search term COVID-19, and this yielded 7,428 results. And actually this was done this morning, but I'm quite sure that already right now we may be at about 7,500 articles that are published only in 2020 for the almost all articles. So it's quite overwhelming. But when we focus then on sedation, then we have not more than 12 results. And this is quite striking. And when you see that it's just expert opinion and also some articles in Chinese, that is a bit too difficult for me. So when we ask ourselves the question, what level of sedation should we apply and which sedative should we use, we, I think, should base our practice as much as we can on sedation practices in normal times, which is supported by quite a lot of articles that are summarized in this practice guideline from the Society of Critical Care Medicine on pain, agitation, delirium, immobility, and sleep disruption, so the PADIS guidelines published in September 2018. And these guidelines show that, or summarize that we should not apply standard sedation. Instead, we should consider whether sedation is really required, really needed to reduce stress and agitation, and realize that sedation has important side effects. And these include delirium, respiratory depression, in particular for opioids, but also hypotension, immunodepression, and prolonged duration of ventilation and ICU stay. Importantly, also striking is that sedation is associated with an increased risk of death. So how do we manage sedation in normal times? I think the first step should always be to treat the underlying cause of stress and agitation and to consider what that can be. Pain is very important. It's underreported in patients. Also, the presence of an endotracheal tube is associated with pain and discomfort. So we should start with aminoacetylphen, paracetamol, and opioids. Many patients have itching. For example, those patients with renal failure. In those cases, an antihistamine can be appropriate. Anxiety is very important to apply reassurance. Alpha-2 agonists like dexmedetomidine and benzodiazepines, also realizing that those can lead to an increased risk of delirium. Delirium is a very important cause of stress and agitation, in particular cases of delirium due to withdrawal, but also cases of delirium due to serotonin syndrome, some overlapping syndrome with delirium. In those cases, underlying causes should also be treated. And in patients with severe agitation or hallucinations, haloperidol can be started. Drug side effects are very important in patients with stress and agitation. Sometimes you see that the dose of opioids is increased again and again in an effort to calm patients, but we should realize that in particular opioids, but also other sedatives, can have a paradoxical response and can lead to further agitation. So we should reduce those agents if we can. We should try it anyway. Dyspnea and patient ventilator dysynchrony should be followed by adjustment of the ventilator settings. Urinary retention and constipation also causes of stress and agitations and should be relieved with the catheter and laxative, of course. So our second step should be to apply non-pharmacological measures. And these are low tech and may not be very sexy, but these include reassurance, family visits, no disturbances during the night, and music. But they are really effective in the way that several studies have been performed on this. It's a very difficult area, so the quality is not always what you would have hoped. A very interesting study is shown here on the use of music, published in the JAMA a couple of years ago, where patients were randomized to receive headphones with their own music, or noise-canceling headphones, or no intervention at all. And music of the patient, so patient-oriented music, was associated with a decreased need for sedatives. Other cases of patients can preferably have non-benzodiazepine sedation, and this is based on several studies that compared this with other sedatives, like a very old study back in 2006, where lorazepam and propofol was compared, and this resulted in less days of ventilation in patients who received propofol. Another paper, more recent, by Pratik Pandaripande, showed that sedation of dexmedetomidine as compared to lorazepam resulted in less days with delirium. When patients are really agitated, we should not forget that alpha-2 agonists and haloperidol can be very effective. There's not so much literature on agitation in itself. Very interesting study back in 2009 from Michael Reed compared dexmedetomidine with haloperidol as a kind of pilot study, and found that patients who had received dexmedetomidine could be extubated earlier compared to those with haloperidol. And this was further shown in a JAMA study 4 years ago by the same group that showed that when patients were that agitated that they could not be extubated, they received sedatives to calm down. In those patients, dexmedetomidine was more effective, led to earlier extubation than patients who received placebo. And another very important concept is to administer short-acting sedatives for a short period of time and aiming for light analgesic sedation. There are several papers already mentioned in the introduction, paper by Kress back in 2000, landmark paper published in New England Journal of Medicine. Another one is shown here that was comparing daily interruption of sedation with no sedation at all, that is analgesic sedation, but no profound sedation. And the result was that patients who had no sedation or analgesic sedation only had a shorter duration of ventilation, a shorter duration of ICU stay, and a shorter duration of hospital stay. Just an illustration of several papers in this field. So we should not forget all those lessons that we have learned. But these are not normal times, and we have patients in large wards where they are nursed together in just close to each other in a completely other environment than we are used to. We need to work in professional ICUs, for example, the PACU, the post-anesthesia care unit, or in my hospital, the military hospital. We may work with non-ICU nurses, non-ICU physicians who are not really used to work with sedation, other aspects of intensive care medicine. And there may also be a shortage of short-acting sedatives like propofol or remifentanil. So how do we manage sedation in COVID-19 patients in Corona times? Well, we should again not forget all those lessons. So let's start with causal interventions, analgesia first. But let's consider whether there are anything that is disturbing a patient, is leading to stress. We should again not forget to apply non-pharmacological measures as good as we can do it. That intervention with headphones, with the music of the patient, can also be applied in Corona times, and this was quite effective. When we are forced to use more longer acting agents like morphine and benzodiazepines, we should use the lowest amount of that, and we can still apply daily interruption of sedation, aiming for light sedation. So another question is, when we face patients in these days with patient ventilator asynchrony, how should we treat that? Should we treat that with more sedation, or should we apply neuromuscular blocking? Well, very important to address this question, obviously, is to optimize ventilator settings first. That goes without saying, but it's really important to stress this. And secondly, let's consider secondly, how breath are generated. These originate from a network of nuclei in the brainstem, that's the dorsal respiratory group, and the ventral respiratory group in the medulla oblongata, and the pontine respiratory group in the pons. And these nuclei receive input from mechanoreceptors in the respiratory tract, chemoreceptors that detect oxygen, CO2, and pH in the arterial blood. In addition, they receive input from the hypothalamus and cerebral cortex, and sedatives inhibit the respiratory drive, but the cortex is much more sensitive for that than the hypothalamus. So when we have a patient with ventilator asynchrony, large amount of sedatives may be required to suppress all inspiratory efforts. And it's important to realize that deep sedation versus light propofol sedation was associated with asynchronies during pressure support ventilation in a study a couple of years ago. Deep sedation may further lead to reverse triggering, which is activation of respiratory centers in response to passive insufflation. So how do we handle patient ventilator asynchrony? Again, optimize ventilator setting first, and make sure that the patient is really unconscious. That is a RES score of -4 or -5, which means that the patient is not responsive to voice, and in case of a RES of -4 is only to some extent responding to physical stimuli only. And we should make sure that this patient is unconscious in this way, remain that for the next 2 hours. In those patients, I would recommend to bolus the neuromuscular blocking agents like rocuronium to treat patient ventilator asynchrony. I'm quite reluctant to apply more sedation, even more sedation, because over-sedation is really a problem in these patients, leading to a very long duration of ICU admission and long duration of hospitalization with weakness as a result. So when this still happens, because it's my experience that this happens quite a lot, that patients really receive quite a lot of sedation, and they do not wake up after discontinuation, what should be our policy, what should be our consideration? So failure to awaken in COVID-19 patients, what can be the underlying cause? Well, first of all, let's consider that the patient may have had a more complicated disease course, and this can include a prolonged or severe hypoxemia or hypotension, hypoglycemia, but also organ failure like acute kidney injury and or liver dysfunction. There can also be electrolyte disorders like hyponatremia. Well, these are causes of failure to awake after discontinuation of sedation that can be found in textbooks, but they do not describe how severe, for example, hypotension should be. This is a very difficult question, and we do not know that even for surgical patients during anesthesia. So let alone for critically ill patients, it's quite complicated. And that has to do, obviously, with things like stenosis of carotid arteries, or the extent of autoregulation that may be disturbed. So this is a very difficult issue. When is hypotension severe enough to result in brain damage that leads to failure to awakening? That's a kind of estimation that we can make. In addition to a complicated disease course, there can be a new event, and this can be a basilar artery occlusion due to hypercoagulation that may cause in itself a comatose state. It can also be cerebral hemorrhage due to anticoagulation that the patient may receive because of pulmonary emboli, for example, or another cause of stroke, or other type of stroke in combination with another cause. It's important to stress that. Many people think that a stroke in itself can lead to coma or decreased level of consciousness in general, but it's not really true. It should really involve certain critical areas like the brainstem or bilateral hemorrhage damage. And the brainstem is obviously damaged in case of basilar artery occlusion. In other cases of stroke, like cerebral media stroke, there should be another cause as well, like over-sedation, or there should be herniation of the brain. In addition to that, we could consider a new central nervous system infection. Patients with COVID-19 are sensitive to or vulnerable to develop aspergillosis. It can also affect the brain. And lastly, diffuse intravascular coagulation with microthrombosis can lead to diffuse ischemia in both hemispheres that leads to a decreased level of consciousness. But the most important reason to for failure to awaken, in my view, is drug overdose. And then we're talking about over-sedation, in particular in patients with acute kidney injury and obesity. And the reason that I say that, the acute kidney injury, is that a lot of patients with COVID-19 have this, possibly related to the immunological state, so hyperinflammatory state, and obesity seems to be kind of risk factor in these patients. Redistribution and impaired elimination are important problems regarding sedation in these patients. So should we then antagonize benzodiazepine or opioid overdose? We could use flumazenil and naloxone for that, which are benzodiazepine and opioid receptor antagonists. But we should not do that, in my view, in a way that antagonizing can lead to an acute withdrawal state where the patient is really severely agitated, hypertensive, and this is also a state that, well, is difficult to treat. So this is not my advice. And I think this is my last slide, so I give back the floor to Björn again.
Thank you very, very much, Arjen, for this wonderful and brilliant overview. And thank you so much for giving such clear messages that were really needed. So I think before answering all of your questions, and our ESICM family is very active in asking them, I would like to leave the stage for Margaret HERRIDGE and her talk on outcomes.
All right, thank you so much, Björn, and thanks, Arjen, for your excellent presentation. I hope you can see my screen currently. I'm just going to talk briefly about some of these themes in the context of outcomes. And I also wanted to indicate that I have no conflict of interest. Just as an overview, I think there is a growing tension between enforcing lung protective ventilation, which is really a major theme here in COVID, and also trying to mitigate long-term morbidity across multiple organ systems, which I've listed here. So I'm going to talk a little bit about these systems now. I just wanted to start by showing this slide that came from a Brussels roundtable in 2016. This was co-chaired by Elie Azoulay and myself and many outcomes investigators. And just to highlight that people come to the ICU with different health status on different health trajectories already. Everyone has a decrement in their function when they come to the ICU, and they often have differential recovery and long-term outcomes, largely based on that pre-morbid or pre-ICU health status. These are some pictures from our 5-year ARDS outcomes program. The one in the 5-year outcomes published in 2003 and in 2011. And I just show you a picture of this patient on the left, a 47-year-old patient with community-acquired pneumonia and ARDS. And here she is 1 year later. And typical of all of our ARDS patients, she sustained almost a 20% reduction in her baseline weight, most of which was loss of lean muscle mass. And even though at 1 year she was back to her baseline weight, most of this was fat, and she had not completely reconstituted her muscle. This is a very nice schematic from a New England Journal review written by J.P. Kress, and I just wanted to highlight a couple of things. One was that the critical illness weakness is really a combination of myopathy and a critical illness myopathy, specifically a myosin depletion myopathy, and a critical illness polyneuropathy, in particular an axonopathy. So again, Jesse Hall, I'm sorry, I forgot to say Jesse's name, but Jesse and JP wrote this. And here are some histology slides of what the muscle looks like. And you'll see evidence of chronic myopathic changes evidenced here by some angulated fibers and hypernucleated angulated fibers. And this is just very pathognomonic of this kind of muscle injury. I wanted to talk briefly about neuromuscular blocking agents because personally, I have never used so much paralytic in ARDS patients, probably for 20 years. And we're using it in a sustained way. I really appreciated Arjen's comments that we really should be using this as a bolus strategy, but often we're using it as a continuous infusion. And it's still a little bit unclear the exact relationship and signal between paralytics and subsequent neuromuscular dysfunction. But in this very nice systematic review led by David Rice and Mark Michelson, they do point to a modest association between neuromuscular blocking agents and neuromuscular dysfunction acquired in critical illness. I'd like to highlight this wonderful physiological review from 2015. And it really goes through a lot of important physiological constructs in the critically ill patient. And you'll see here I've outlined that neuromuscular blocking agents, the prolonged neuromuscular blockade, the signal, as I mentioned, may be not completely straightforward in the published literature, but without a doubt, prolonged use of neuromuscular blockers will result in unloading and denervation atrophy. And the prolonged use of sedation, as Arjen nicely outlined in his talk, sedation and that kind of immobility will definitely potentiate disuse atrophy and will increase protein degradation, increases upregulation of the ubiquitin proteasome pathway that we know is present normally as a regular housekeeping function, but is upregulated in times of stress. And also immobility as well, we understand will promote autophagy. Again, in a very nice review here, some of the things contributing to critical illness myopathy that I've outlined here. And we're talking about a lot of these issues right now in COVID. And sedation, mechanical ventilation, all of the ways in which we optimize and are targeting low tidal volume ventilation, and really trading off lung injury with end organ injury. And the end organ injury here that we're talking about is nerve and muscle, is brain, as Arjen alluded to, but is also a whole host of other things, which I'll talk about in a moment. This is a nice overview of how early immobilization, muscle unloading related to sedation, paralytics, mechanical ventilation, and some of the cellular and molecular mechanisms of that. And in the later phases of the critical illness, where you have other effects that take place. So just to highlight these with some literature and some landmark papers by Sandy Levine in the New England Journal in 2008, showing unequivocal upregulation of the ubiquitin proteasome pathway within hours of mechanical ventilation. Very important observation. This was in the diaphragm of this is a post-mortem evaluation. And then a very important study published in JAMA, led by Zudin Puthacheri, Hugh Montgomery, Nick Hart, Steve Herridge, others involved in this important study, showing a relentless degradation of skeletal muscle within the first week of critical illness, and how important that was in terms of outcome. And then important later work. This is a beautiful study authored by Samir Jaber, showing how when we move from short-term to long-term mechanical ventilation, we have important architectural changes that occur that may be fixed, and disruption of the sarcomeric architecture. And this may be one of the reasons why we have fixed challenges with weakness and contractile force that may not necessarily be rehabilitatable in the post-ICU patient. I'm going to show some data here from our one-year ARDS project, but also our group did a one-year outcomes project in SARS, which we really were challenged by in Toronto in 2003, and we learned a lot from it. It's a paper led by my PhD student, Kathy Tansey. And I want to contrast a couple of things. The muscle wasting and weakness that we observed in the critical illness, myopathy and neuropathy, were manifest as a decrease in distance walked in 6 minutes. And you'll see at 1 year, this cohort was only able to walk 66% of an age and sex match predicted control. I would contrast this here with our SARS cohort, most of whom were not in the ICU. And this will be typical of COVID, where as intensivists, we're seeing critically ill COVID patients. We are not seeing community COVID patients, which vastly outnumber our critically ill patients. And I will show you here that at 1 year, the distance walked in 6 minutes was above 80%, although still likely representing a decrement in function in a largely very young group of patients who were young healthcare workers. I also wish to outline that in those folks who survived their episode of ARDS in our 1 year study, did not have important pulmonary dysfunction. There's a lot of publicity about the ground glass opacifications in the COVID patients, concerns about long-term pulmonary fibrosis. We await still long-term outcomes data on the COVID patients. Our own group is engaged in a provincial study in this currently, but we await that. But generally speaking, ARDS patients without pre-existing pulmonary function do not have long-term problems. And this is also what we saw in SARS. one point I would really like to emphasize that I tried to begin the talk with is that it matters a lot who you are, how old you are, how frail you are, your burden of comorbid illness, how long you stay in the ICU, your pre-ICU health status, in determining how you come out on the other side and are able to rehabilitate. Older patients in this nice study led by Amber Barnato, who already had baseline disability, had a lot of acquired disability when they had been hospitalized with mechanical ventilation. This nice study led by my Canadian colleagues, Sean Bagshaw, Tom Stelfox, and others, show very clearly that frailty is common among critically ill patients aged 50 and older, so not necessarily our older patients. And this was a very important risk factor for morbidity and mortality. A very important paper published by Jack Awashina in JAMA in 2010, showing very clearly that level of baseline dysfunction here on the y-axis as the mean number of ADLs or IADL limitations will jump dramatically after an episode of critical illness, here an episode of sepsis. A very nice paper published by Mark Unroe and colleagues from Chris Cox's outcomes group, who also work with Shannon Carson and others who are leaders in chronic critical illness construct and some important outcomes work in this area, show very clearly that patients who've been mechanically ventilated for several weeks will go on to have a lot of functional disability, mortality, and poor outcomes. And your functional trajectory, and this is among older patients published by Lauren Ferranti and Margaret Pisani and others, has a very important impact on functional decline over the year after, or has an important impact on the outcomes on the other side of the episode of critical illness. I also want to emphasize this work from my colleagues here in Toronto and their MEND ICU program, Jane Batt and Claudia Dos Santos, showing that after critical illness, patients will have differential recovery of not only muscle bulk, but contractile force. And muscle bulk and contractile force may be discordant. So the way in which people recover after critical illness has a lot to do with their pre-morbid health status, as I mentioned, but also recovery can be differential. And this is just outlining that. I want to briefly highlight what Arjen said. The brain is very vulnerable here to sedation, the impact of delirium, and there's cognitive dysfunction here in terms of decrements in processing speed, memory, executive function, attention, and concentration, outlined in this landmark paper by Mona Hopkins in 1999, and an age-inappropriate loss of, or age-inappropriate cortical loss, pardon me, and really in a very striking way here. This is a slide that Mona lent to me. And as Arjen alluded to, this important New England Journal paper led by Pradip Pandarapandi with Wes Ely, showing that patients had a decrement in cognition on the order of mild Alzheimer's type dementia or moderate TBI across all age groups. And the most potent risk factor for this was duration of delirium. Our patients will have mood disorders. Delirium and persecutory delusions are a risk factor for PTSD. Patients on ECMO may need to be restrained. This is an issue in my own ICU here. Mood disorders likely have a structural construct, and it likely relates to injury in the amygdala and other areas of the brain. From the PTSD literature, we are likely potentiating that in the critically ill patient and potentiating many components of the post-intensive care unit syndrome. But I just want to make the point quickly in the last minute or so that disability is very heterogeneous. So in addition to what I've already mentioned, you might have, in extreme cases, some pulmonary morbidity, not usually, but when the lung is exposed to extremely high airway pressures, you will get injury in the baby lung. And here's some evidence of fibrobullous changes in a patient on high frequency oscillation with very, very high mean airway pressures. There are lots of other issues, tracheostomy, which we're not doing as we usually do in our longer stay patients. This is a deviation from practice, which is a little bit problematic, as Arjen alluded to. Patients may have tracheal stenoses, lots of pressure ulcers from being sedated and immobilized. These are a source of sepsis and a source of complex recovery. Contractures of the shoulders, also a sequela of immobility, and all sorts of other sequelae related to a long length of ICU stay. I want to highlight the caregiver who, through all of this, is very traumatized. In particular, now it's a beautiful study by Ellie and Frederick Couchard, Nancy Kentish-Barnes, and others, showing very clearly how PTSD affects family caregivers. A nice paper by Chris Cox, again, is showing this, and some recent data from our own Recover group showing how caregivers may have moderate to severe depressive symptoms, 27% out to 1 year. So, and that stress in the caregiver is actually an independent risk factor for mortality in this JAMA paper in 1999. So to summarize then, baseline health status is very important, and we need to challenge how we tailor our mechanical ventilation, our sedation paralytics to baseline function, and think very hard about the trade-offs across multiple organ systems, because these are trade-offs as we try to optimize our lung protective ventilation. Unloading atrophy relating to sedation, narcotic use, prolonged neuromuscular blocking use has a very serious cost and a long-term cost to our patients. And as the patients stay longer in the ICU and are isolated from their family members who wait at home now, who have no idea really what's going on, who are isolated from decision-making and have disrupted communication, this is extremely traumatic life event. And our challenge going forward is really to mitigate lung injury, yes, optimize care of the patients. I would emphasize what Arjen said, trying to observe published standards of practice while preserving organ reserve resilience so that our patients can rehab and recover after they leave our care. So I'll leave that there, and thanks again for the opportunity to share these thoughts with you.
Thank you so much, Margaret, for this wonderful overview, and thank you very much for also making us aware of all these long-term consequences that will likely occur and which we haven't seen because the disease is still so young. But I think we all agree that we also have to look at this. So now it's the time to ask questions, and I got a lot of questions via WhatsApp, via mail, via the chat forum here. So I try to organize them a little bit into a more acute phase questions and the long-term questions. And I think, and I also tried to a little bit to summarize questions because I got so many that we probably don't have time to go through all of them. But there have been several questions about the enormous amounts of sedation that seem to be necessary in COVID patients. So many of our users said, this is very unlikely that these patients need such a high amount. And is there a pathophysiological cause for this? Maybe Arjen, as a neuropsychiatrist, you can elaborate on that a little bit. Do you see any kind of specialty in these patients, or is it just that it's a normal ICU patient that is not always septic, especially if we think about the different types of the hypo and hyper-inflammatory state of these patients?
Well, I think it is really striking that how much sedatives these patients receive, and the observation that they really require so much sedation is made by you, Björn, in Berlin, but I've also heard it from many colleagues in the country. So this is something really, really special for these type of patients. And actually, we do not know what can be the underlying reason for this. So it's very speculative. There are quite a lot of things that are really different compared to normal times. We are working with other agents. In our institution, we left sedating with midazolam years ago, but now we are forced to do so because there's a shortage of propofol and remifentanil, which is coming back to normal amounts, fortunately. But that's what we have seen. In addition to that, I think that there's also a kind of effort of kind of idea of a lot of us to really suppress all those respiratory efforts with even more sedatives, and in the case of patient ventilator synchrony. And this can lead in the short term to a better situation, but in the longer term, those sedatives are accumulating in fat tissue, and the patient is really more difficult to treat, in my opinion.
Yes, I have another question that actually goes into the same direction. One user asked, a colleague asked, that he sees extremely high doses in midazolam, which he's forced to use because of a shortage of other drugs in his intensive care unit. And he writes that it's up to 50 milligrams per hour, and that it's really concerning to give so high doses. And he was wondering if a multimodal approach involving ketamine and opioids and alpha-2 agonists would be probably the way to go, which I would definitely say yes, if I may allow, before giving this question to both experts.
Do you want to comment on that, Margaret, or shall I discuss this as well?
Yeah, please, Arjen, go ahead. Yeah.
Right. I'm myself a bit reluctant to administer ketamine, I must say, in a way that a lot of patients develop hallucinations. And when we do not specifically look for that, it looks quite okay. But in many patients who have received ketamine, and you really ask when they have a level of consciousness that allows to have verbal interaction, then a lot of those patients have hallucinations. So I must say that I'm quite reluctant to administer that. In those patients who have really a kind of patient ventilator dysynchrony, my approach would be to stop as good as it can the benzodiazepines in that situation. And when there is really a very severe situation that cannot be handled otherwise, to switch to alpha-2 agonists like dexmedetomidine or clonidine. In our institution, we administer a lot of clonidine. I think it's a very good drug in a way that it's much cheaper than dexmedetomidine, but it works very well. It has more hemodynamic effects. But those patients that are agitated usually have a hypertension and are tachycardic. So that's not so much a problem, I think. So my brief answer would be stop the benzodiazepines and go on with alpha-2 agonists.
I can just make a comment if that's okay as well. Yeah, Arjen? I worry a lot. I've been attending, and I worry a lot that the patients really develop tachyphylaxis to all of these massive doses, and that actually they are really awake under the paralytics. I would just say that from some of our outcomes studies, many patients over the years have told me that they are awake. And some of these folks were folks I definitely looked after myself. And they could tell me, they'd remember my voice, some of the things that I'd said on rounds, and there's no way these could have been reconstructed memories. And they were telling me, that they were awake, that they were in pain. And I think this is a real risk that we run when we're reassuring ourselves, perhaps, that there's no way the patient could be awake because they're on so much drug, but in fact, over time, maybe accommodating to the drug. And they are really suffering in ways that we really can't understand because we're so disconnected because the patient's sedated and paralyzed.
Well, that's a very important point, and let me put this right. I do not want to plead for the application of neuromuscular blocking agents in patients who are awake. Definitely not. Of course, what I'm talking about are patients with RASS -5 who are not responding to anything, and in whom there is just a patient-ventilator dysynchrony. And in those patients, I think to administer even more sedatives to depress all respiratory efforts really leads to oversedation. In those patients, I would administer a bolus of neuromuscular blocking agents. But what we discussed in this question was actually more those patients who are still having respiratory efforts without, perhaps I did not understand it correctly, without a level of consciousness. That is a patient who is more deeply sedated. In those cases, I would try to stop all those sedatives again and to go on with alpha-2 agonists.
I agree. Thank you very much both for your answers to this. Margaret, I would like to ask you,
Sure.
because you mentioned that patients have disturbing memories, especially if they have delirium, and if they are in a state between, you know, being awake and aware and being still in like this kind of horrible dream, this nightmare. What do you think? Will we see another wave of mental health issues? Do you think after COVID we will see a lot of psychiatric comorbidities arising more than usual?
Yeah, I would say, Björn, that I would really worry about that, to be honest with you. One of the main findings from our SARS cohort that we did many years ago, that Kathy Tansey led, my graduate student, one of the main findings was really mental health, much more so than physical health, because remember that SARS, at least in Toronto, affected mostly healthcare workers, and they were young, pretty healthy people. So they had pretty good physical recoveries, but they had enormous mental health challenges, actually. They were a very stigmatized group. Everyone in Toronto was terrified of SARS. So they were stigmatized, they were isolated, and people had harrowing stories of how they'd been treated because people were so terrified of them. I also think the COVID patients are a stigmatized group, will be a stigmatized group, and will suffer in many of the similar ways that the SARS folks did. But I really would fear that we have a lot of mental health needs, which, by the way, are there for all critically ill patients and families at baseline, and are just heightened or exacerbated by the COVID pandemic. And I think they, you know, across many countries, mental health resources are modest at the best of times. And these folks are going to really need a lot of careful mental health attention after they get physically well.
Do you think in this context that we should offer patients, I mean, this is something we're discussing about, let's say in our area, in our peer group for quite a lot of time. Do you think we should offer them a routine assessment after 3-6 months to identify those suffering from PTSD and offer adequate help before seeing like all the comorbidities arising with that?
Yeah, I do. Our own group is starting a 1-year provincial sort of multi-center follow-up study. I think the physical needs will be the usual physical needs, except maybe aggravated even more by the sedation and the paralytics. But honestly, I think even more, we're going to really need to help take care of the patients and their families who've been through such a difficult psychological trauma. And I think the families, it's going to be even worse because they've been so separated from their loved one in a way that's not normal anymore. You know, we're used to having our families on rounds, talking with us in person, and now they're, you know, it's just, you know, a completely opaque curtain. They can't see their loved one being sick. They can't talk to us. They can't see what's going on. We've been trying to FaceTime families on our rounds in the unit here. We try to talk to them on the phone every day, but it's not the same. And they're really getting very traumatized, I think. I think they're going to need a lot of help on the other side of this, yes.
I agree very much.
Yeah, you agree? Okay. Is there something in the Netherlands done, like a regular post-ICU rehab clinics?
Yes, there are several initiatives for that, and I think in the Netherlands there is a recommendation, a guideline of the Society of Rehabilitation Medicine in the Netherlands that it should be standard care to have a follow-up after ICU admission. And with all the attention that COVID-19 patients have, this is a very good moment to start this, because the morbidity after critical illness is really profound. Margaret has done fantastic research on this and showed this very clearly in several ways. It's not just the physical impairment that people have, but also very much the psychiatric problems as well. And this also applies to family members. So yes, I think this really should receive more attention.
Yes, I fully agree with both of you. You see here in the background, this is our enhanced recovery program. So we are also doing this. And I think it's a good idea also to offer this opportunity to community hospital patients where it's often like more difficult to implement research. We have the privilege of doing research studies and so offering our patients to participate in these studies. I have a question that is directly linked to it, because people are worried about the change nurse-patient ratio, decreased opportunities to provide reassurance, families not allowed in the ICU anymore. We have the stuff in spacesuits, and we have like these potential risk for psychological long-term consequences. Do you have any practical things, something you can tell us from your ICU? How did you implement non-pharmacological measures in this really, really difficult situation? Do you play music, Arjen, in the ward now?
Well, actually, this is something that we can apply, but we should do it more. What we have is, let me say, when we had our first patients with COVID-19, this was not really feasible, because although we had not a terrible situation like our colleagues had in Italy or in the south of the Netherlands, where there was really a very massive outbreak of COVID-19, we could prepare a bit better, but still it was things were going very rapidly. So in the beginning we couldn't do that, but when things stabilized a bit, we have again applied our usual practice, that is to have diaries for all patients, where 2 studies have investigated this, showing a decreased frequency of PTSD in the long term. And what we also are doing is that we have a sheet of paper that is describing what kind of patient is lying in the bed. So the family is asked to characterize the patient, what are his or her hobbies, what are his or her interests, things like that. And that really helps to have a sheet of paper at the back of the bed of this patient, because it turns out much more a human being in that way, instead of just kind of object generating figures and graphs like you described at the introduction. So I think that also has to do a bit with our attitudes towards the one who's lying in bed. I think that really helps. I think it was an initiative by one of our nurses, and I think that's really great.
That's great, yeah. Margaret, anything to add to that maybe?
I think all I would say is that there's such a tendency to, it depends on your unit setup, but we have individual rooms here at the Toronto General. And it's very difficult because the patients, people are trying to minimize the contact with the patient to minimize exposure. And the patients need us to talk to them, to touch them, to examine them, to interact with them in a normal way. And I think that is a big challenge. But I think with our PPE on, we need to go in and spend time, actually. And remember that there's just a person under there. And
I
that
agree.
it could be us. I say to the house staff, if I'm sick here, I want someone to come in and examine me and talk to me and interact with me. So yeah, I'm worried. It's normal, but we need to do it. It's important, I think.
Yeah, thank you very much for this comment. I think it's really important that we sometimes, go a step back and say, in all of this kind of emergency, what we're doing, it's very important to still think of the little things we can do despite delivering ventilation and saving somebody's life, because in the end, we will also have to deal with a lot of these comorbidities arising. I got a lot of questions here regarding concrete substances, and I'm very, very sorry, but we cannot ask all of them. But I would ask, because there are so many questions on this, I would ask one question to both of you regarding the question volatile anesthetics in the ITU. Do you have experience with it, and what do you think about it for COVID-19 patients? Sorry, this is a little bit out of the topic now, but there's so many questions about it. I think we should give a comment on that.
Shall I start? We have had 3 ICUs where we had COVID-19 patients. So in addition to our own ICU, we had an ICU made in the post anesthesia care unit, where indeed volatile anesthesia was applied. It was for a brief period of time, because the number of patients is decreasing, fortunately, now. And we do not longer need that unit, so we have applied it not for more than a couple of days. So that's all my experience, and I haven't heard of colleagues of different patterns of sedation or agitation or anything like that. So very limited experience.
We've used volatiles only in the context of a research study. It's not a usual part of our care here.
I heard a lot about these questions, and I can maybe add there that we're in Germany, that there are several units using it. And if that's my personal opinion, if you are used to it in the normal post-operative cardiac surgery context, and you are known to it, and you're familiar with it, then it might be an option, of course. But what I'm always a little bit hesitant about is recommending something completely new where you don't have experience. For example, some of the systems have more dead space, so the patients tend to retinate more CO2, things like that. And these things, having it in a very stressful situation, can even add stuff to the stress, stress to the stuff. So I would say use what you're used to. Any final remarks of you two you want to make?
Well, I think it's a great initiative of the ICM to organize this. So many thanks to them, and many thanks to you too.
Thanks. And I would echo the thanks, and thanks for the honor of participating today with each of you. It's great to see you remotely. And it is a great and important educational initiative on behalf, on the part of ESICM. So, I'm sure we're all very appreciative. Thank you.
Yeah, I would like to join in you, and I really would like to say a huge thank you to our speakers, of course, to Arjen SLOOTER and Margaret HERRIDGE, and for giving such wonderful talks and for remembering us that it is just about this quality of treatment that really counts, and sedation is an integral part of our management of these patients. I would like to thank the ESICM for allowing us to talk. I would also like to thank Aspen Pharma for their unrestricted educational grant that supported this webinar. But most of all, I would like to thank you out there, all of you, taking the time to join us. I just want to say you're doing a fabulous work. Be proud, stay part of our community, keep educated, keep joining these very, very important webinars, and most of all, stay safe there, and all the best. And I hope to see you in person very, very soon again. Bye-bye.
Bye. Take care.
Take care.
You guys too.